please.
Well, good morning. Happy to talk on our subject today on medication deprescribing. This is an area that I just kind of spent a lot of time on this part on how we get medications off of a resident's med load, and just so many parts to this, and happy to kind of give an overview of how we work at trying to reduce the total number of medicines that we have. Next slide, please. So this is all part of, like Dr. Ross said, part of the 4 M's framework. And all of this is these 4 M's linked together, what matters, what's important to the resident. And then the medication part we're going to talk about today is that if the medication is necessary, you want to use age-friendly medicine that does not interfere with the other parts of the 4M model. In other words, mentation. We don't want medicines that will produce confusion and dementia. And obviously medicines can also affect mobility and the fall risks associated with that, stability. So we're kind of looking at how these are all connected. And today it's medication. Next slide. So our learning objectives today, we're going to talk about define deprescribing and a little bit of why it's necessary, why the elderly are at increased risk for polypharmacy, if you know that term, which medications are at high risk, and review a process for deprescribing. And I want to mention a geeky word called homeostasis, which is just something I think is important to remember when we think about this topic. And I'll have some references for you. So let's go to the next slide, and we're going to define deprescribing. Deprescribing is the process. This is from the American Society of Consultant Pharmacists, the process by which medications are discontinued after a careful and comprehensive review of the risks and benefits of the medications to the patient. Now, the Patient and Safety Network, which is AHRQ, does have another similar definition I think is helpful, a process for supervised medication discontinuation or dose reduction to reduce potentially inappropriate medication. So we're looking for medicines that aren't working well with that resident, and those are the areas that we like to start. So that's one side of the coin, is deprescribing, trying to get residents off of too many medicines. On the other side of that coin is polypharmacy. And so this is the reason why we need to deprescribe, is because so many medicines are on a resident's chart and they're taking. So polypharmacy is defined as the act of taking 5 or more medications on a regular basis. And some other definitions include medicines that are inappropriate, that are on a resident's list that they're taking. And so sometimes that definition is added to. Pharmacists like to, we have this term, the rule of 5. And it basically means, holding up 5 fingers here, if you're taking 5 medicines, at least 2 of these medicines are likely having an interaction. So once you get to 5 or more, we're really looking for how these drugs are interacting with one another. Go to the next slide. Some of our goals of deprescribing. I like this little cartoon here, this little man talking to his physician. He said, is there a pill that I can take to feel better about all the pills that I take? So I've never had a resident come at me with that question, but I can tell you that I have felt like, after looking at so many medicines, that I need the pill to calm me down, because I see some people come in the long-term care that have accumulated a lifelong list of medications. I think my personal record, some of you may exceed this. One lady had 38 routine medications, and it was page after page. And when you added, I remember this, and when you added in the part-time PRN medications, she was at 52, and she took them frequently, 52 orders. I mean, it was a scrambled egg like nothing else. And it really becomes so complicated when you have someone that way. Goals of deprescribing, here's some general understanding of our goals. It's going to kind of narrow itself down as we go through. Obviously, to improve some patient-specific outcomes, reducing medication burden or harm while improving the quality of life. Obviously, we're taking things off so life is better. And then specifically, we're trying to identify medications that are no longer of benefit or may be causing harm. Let's go to the next slide. I want to show you a couple of graphs here, I think, to help you sit this in your mind. This is from the CDC, and it's just kind of talking about number of medications. It actually is comparing us to Canada, which I don't think is all that important, but the data is how many are on one or more prescriptions. And this is looking at an older group, not younger people. So we're looking at age 40 and over. Look at on the right-hand side where it says 5 or more prescription medicines. You know, you're around age 50, and about 14% of us are taking that many. But when you start getting to the 70s, that jumps up about 2.5 times more. And that doesn't really include our older peoples. And I can tell you the number is pretty regularly above that. So we know it's an issue. As you age, it's age related. We're going to talk about some reasons why, but now I want to show you in the next slide why this is important. This is a study that came out of the journal Nature. Go to the next slide if we can. And it's just looking at the association between medications, number of medications, and adverse events, and how does polypharmacy affect people. And the hazard ratio, if you look to the left here, is talking about hospitalizations. How do you correlate the number of medicines to hospitalization? This is a really large study done over a significant amount of time, and it looked at different models, but you can see the trend there is the more medications at the bottom that you see, 1 to 2 up to 78, the number goes up pretty dramatically for hospitalizations. Now, with that in your mind, look to the right, you'll see the next part graph that shows mortality, increased risk of death. As you get more and more medications, here is that hazard ratio climbing really significantly once you start moving up in the number of medicines you take. So hope that sets into your mind why there's so much concern about polypharmacy and making sure everyone's on what they need to be on. Why are the elderly at an increased risk of polypharmacy? I've just put together a few ideas related. More chronic diseases, obviously, as we age, more things break down, and obviously the solutions to that are more medications. Disjointed care among multiple prescribers. For good reasons, we have plenty of specialists that are working, and all of them have maybe their own area where they're adding medications in our situation here, and then they start to accumulate. And so good communication is really important. Here's a term you may not know, prescribing cascade. Now, what is that? Prescribing cascade is when you start a new medication because of another medication that you're already on. So maybe you have a side effect, and so you add something else. Some of these are expected, like some diuretics, where you're going to drop in your potassium. Likely you'll need potassium to replace that. But other situations where adverse reactions occur, sometimes they're expected, and we have this cascade where more medicines are being added to the list. Transitions of care, once someone goes through the system, through hospital and rehab, many times their medications are added. And so there's a process of trying to figure out if those are still needed. And just on the risk side, obviously our older geriatrics were concerned about falling, concerned about weight loss, the dementia that may already be there. We're concerned that medications are going to make that worse. Polypharmacy is a big issue because we're looking for those medicines that would make all 3 of those categories worse. And then I've added the use of OTC medications. Sometimes, especially if they're from home, they don't always tell us everything they're on. And there's a lot of interactions that can be happening just from over-the-counter medications that they're taking. So here's some reasons why polypharmacy is a problem. How does the state, I added in some regulatory issues that are helpful because they're kind of set some guidelines for us. The state uses the term unnecessary drugs. I think we've talked about that before, but the concern here on unnecessary drug, here's the reading in the language. It says must be free from unnecessary drugs, and it defines that for us. Unnecessary drug and in long-term care is when it's given in an excessive dose, in excessive duration, you're taking it longer than you need to, without adequate monitoring. So we're not checking to see if the medicine's continuing to be effective or not, without an adequate indication. So every routine medicine you take ought to have some diagnosis that's matching up with that. It has to have a reason. And then in the presence of adverse consequences, honestly, just saying there's side effects going on. Have we identified those things? And if they're ongoing, what are we doing to get them onto a different medicine or changing the dose or of some sort? So that's how the state looks at that. There's also another regulation on the next slide, which talks about just the psychotropic. So this is an area in polypharmacy where we really want to focus in, and you may or may not be aware that the state has pretty strict guidelines on that. Read the wording here, and this is from FTAG 757 still. It says residents who use psychotropic drugs receive gradual dose reductions and behavioral interventions unless clinically contraindicated. Catch this last phrase here, in an effort to discontinue these drugs. So from the state's perspective, if you come in on a psych medication, their plan is to try to work you off of that. That's where the regulations lead you, unless you can show why it's needed to be maintained regularly. And so that requires documentation. Helpful to know. On the last mega rule update, they added in some more regulations about PRN, psychotropic medications, in reality, limiting them just to 2 weeks. And so they're really trying to limit the amount of medications in this category in older people because of their side effects and because of some of the tolerance that develops unless you really need them. And there are ways to extend that 2-week period, but it's just an effort to try to get some of these medicines down and not used as often. All right, let's go to the next slide. Gosh, that's a lot to say. Where do you start with that? I've listed a few here areas that we're looking for when we see polypharmacy and how do we deprescribe. We start with those medications that have a high risk of being inappropriate or unnecessary. And here are a few things that we see a lot of: addressing duplicate therapies. Many times people are taking either by purpose, because they need to have more medicines to treat one disease. Sometimes that happens. You see that in diabetes and in hypertension. We see multiple medications. And sometimes it's just an error where maybe two physicians are treating the same thing. Maybe they've gone through the hospital. I see this where there's a formulary where they move from one drug to another. And somehow when they get discharged, both drug names are still on the list. And they're doing the same thing. So duplicate therapy is an area that we look for. Strongly anticholinergic medications is a huge category in the elderly. We don't like anticholinergic medications because it kind of augments the problems they already have. Issues like constipation or worsened, risks of falling increase, dementia and confusion increase. The higher, the more anticholinergic medications you take, those tend to be cumulative. So we're really trying to avoid some of these medicines, and they're in very common medications that we would see a lot of. Drugs like urinary incontinence, several of our cardiovascular medicines fall in this category, some of our psychotropic medicines, and some of our older antidepressants are all anticholinergics. And so we're constantly looking for that class of medicine and trying to work them away from it. Just think of medicines concerned also in the pharmacokinetic pathway. Remember that we get rid of medications in two basic ways in your body, through the kidneys and through the liver. And as you age, remember this, once you hit age 35, they say you lose about 1% of your kidney function every year. Now, how many of you are doing the math right now to figure out how much kidney function you're still going? So by the time you become elderly, really you may be running about 50% of what you were, and that's normal. And so we're watching these medications that get excreted renally to see if they're accumulating, and so we're watching that class. The other pathways through your liver, and the biggest problem there is a lot of medicines are processed through the enzymes in your liver, and so there's these interactions that occur. So there's several classes of medicines that interact with one another, and that's a constant area we're looking for, and sometimes that helps us address deprescribing. Medications that are highly protein bound, that's an issue, especially if someone's not eating. If the medication's attached to the proteins that goes through your body, then if your protein levels drop, those medications have a larger effect. And so this is where dietary connects with medication use. We have a whole list of medicines that we kind of keep track of if someone stops eating and we're concerned about. Long-acting hypnotics and anxiolytics is another area of polypharmacy we're concerned about. We don't like medications that run in quick and last a long time, because they can cause some delirium if they run in too quickly and fall risks. And if they hang around too long, they produce kind of a hangover effect. So we're looking for this class of medicines, of drugs that go in slowly and leave quickly. And so we have a list of those too. So these are all some of the medicines we're looking for reductions. Obviously, the high use of opiates is a concern, combined with other medications that cause cognitive confusion or decline, affects our 4M model. We have several references that are available. Many of us enjoy using the BEERS criteria. The American Geriatric Society comes out with that every few years. 2019 was the last update. And it really helps kind of get a list of these medicines that we're most concerned about and the ones we like to work on for deprescribing. All right, that's a lot to say. Let's go to the next slide. Also, where to start from the family practice management. There are 4 key parts of deprescribing. This is just a simple plan, and that is to review all the current medications at a sitting. Sometimes if you're in an outpatient setting, I've done some brown bag reviews where people bring all their medicines together, you lay them out on the counter, you just start going through them. I've done this with my own family members, as well as just in the community, and it is shocking to see some of the medications that are brought in that I don't think anybody knows that they're taking or where they got it from. It's just always really interesting. And it's been having a time where you sit down and kind of make a point of matching up these medications to make sure they have a clear diagnosis and a purpose is helpful to see where you are. Number 2 is to identify those inappropriate, unnecessary, or harmful medications, some of those we just talked about, and then talking to the patients about, are these medicines still needed? Some of them they desperately want maybe even more of, or changing something, and then some of them they said, that's not an important issue for me anymore. So having the patient involved in that process is important. And then making a plan on how to deprescribe these medications with the residents so they're on board and understanding the reasons why we're trying to reduce some of this. We like to taper them slowly and to try to do one at a time when it's appropriate. And of course, we'll need to monitor the symptoms of the disease to see if things get worse and watch for any withdrawal effects when you take someone off of some of these medicines. And then number 4 is just, this is the process. This is to regularly review the medications again, because as soon as you make any progress, after time, they just start to accumulate again over different disease issues or events. And so it's an ongoing process. And there's the encouragement to involve your clinical pharmacist to help out with some of that review. All right, let's kind of go. There's a few statements here. I won't have a lot of time to mention, just I wanted you to know about them. I know ASCAP has this choosing wisely statement. I think AMDA has a larger list. ASCAP has just kind of these 5 different categories dealing with anticholinergic medications, transitions of care, and making sure that you don't have a prescribing cascade going on and how to stop that. Larger statements you'll see with AMDA, and choosing wisely is something you can Google and just see kind of what's on the top list. These are very helpful to help you kind of focus in on what areas you want to work on. Next slide, please. Another really great program was a joint effort by AMDA and ASCAP and the Society for Post-Acute and Long-Term Care. It's the Drive to Deprescribe. This is a great program. The goals of this is to address polypharmacy and inappropriate medication use in our setting to bring awareness of the high polypharmacy rates, and even sets a goal for your facility of working to drop usage by 25%. And it sounds like a lot, and it is, but it's a process of working step by step and watching your numbers. This organization helps provide opportunities to engage through facility enrollment, so you can enroll your facility. Individuals can also enroll and participate. They have monthly webinars and discussion groups that get together and talk about how to tackle the problem. And if your facility is enrolled, they also have data collection, and they have facility measures that you can compare and see where you are and see how successful the program is working. So Drive to Prescribe is a great area to start as well. The next slide. So in the last few minutes here, I wanted to mention homeostasis, and sounds like a little scientific word here, remember biology, but I think it's important when you think about taking residents off medicines, and there's a lot of that goes into this area. Homeostasis is a movement toward a stable state. Guys, hang with me a minute. I think I'll try to explain this to you. I've got this little picture up there on your left of a little teeter-totter, about how you remember in grade school when you're balancing yourself out and you have a friend and y'all are just kind of getting everything worked out, and that's fun and great. Your body is constantly doing, God has designed our bodies in such a way that everything just balances out real well. It handles difficult situations and changes pretty well. The example I put in here, if it's too hot in this building and you start to sweat a little bit, it'll bring your temperature down. And if you're too cold, you'll probably start to shiver and your temperature will go back up. So this kind of an equilibrium that your body produces happens at every level of your body, even down to the cellular level. And so medications in some ways, sometimes produces an artificial imbalance to some of those things. And I like to use the example of acid reducers. If you guys are familiar with Nexium and Prilosec, those are some common medications we use to stop the acid, and they're really strong. They work very well. And so what happens is the amount of acid in your stomach gets dropped dramatically. And it's interesting that your body knows that it doesn't have enough acid. And if you think about it, what does your body respond by doing? Think for a minute. It starts to try to make more acid. And you can actually see the morphology in your stomach changed in an attempt to make more acid, but it can't, really, because the medicine's stopping the acid production. And that's okay and fine and good until you stop taking your Nexium or Prilosec. Give it about 24 to 48 hours, and all of a sudden you get this flood of acid and life is miserable. And you think that maybe something's wrong with your stomach. And in reality, it's a medication effect. So we have to be aware of what can happen. This is true of a lot of medicines, sleeping medications. Your body will not rest or sleep if you just stop taking sleep medicines that you've been on regularly for a long time. Your body has become tolerant and adjusted to that. Very true also for antidepressants and the amount of serotonin that it adjusts to. And when you stop taking these medicines abruptly, you have a real problem. Have you ever had go back to grade school and you're on the seesaw and your friend jumps off the other side? What happens? You probably lost a friend, and maybe started a fight, I don't know. But that kind of what happens when you take medicines off too quickly, and people will crash and have real problems. So you have to be careful. Homeostasis produces a dependence for normal functioning. It leads to lower responsiveness, and you end up taking higher doses. And this is why we see in the geriatric field an accumulation sometimes of several medications that we've added and built up because the first ones didn't work, or they wore out and stopped giving us that effectiveness. So you end up with cocktails and more medications than we wanted to have. So therefore, when you think about gradual dose reductions, or GDRs we call them, it really has to be gradual. It takes a real art and a craft to understand when you want to take something down and try to do it gradually, and so that we don't have some of these side effects. So I hope that's helpful when you think about deprescribing. I've left you some clinical resources here. This slide, I think there was another that Dr. Love was donated, that she did an echo program at UNT, and this was very helpful. They have some pocket guides for the Beers criteria. It's also available online. So you can download it to your computer if you want to know what medications and what drugs with certain diseases are not recommended. Those are great places to find that. Deprescribing.org is a wonderful site. It brings in some evidence-based deprescribing. I think they've chosen, if I remember right, I think 4 areas of drugs, classes of drugs to work on, and they give you algorithms on questions to ask, kind of a flow chart on how do we go from here, A to B, to try to reduce these classes of drugs. Maybe they're going to add more later, but it's a very helpful website. Also on deprescribing.org, they have some testimonials, which I thought were really great. You can go in and listen to the patient's story and sometimes the caregiver's story on, what happened in polypharmacy and how deprescribing benefited them. So it's a great resource. There's some stop and start criteria, which is great for looking at medications. Don't forget to utilize your clinical pharmacist to help you with this. And American AGS has a deprescribing toolkit, which a lot of resources there I think you would find very helpful. And this last slide, I've left you with some references to look over. I have found when I was doing some research on this program, there are a lot of agencies and a lot of organizations that have deprescribing almost in every area of medicine. You'll find a deprescribing part of that discipline. So it's just very interesting. You can find so much information in a lot of locations. So I hope this has been helpful. I'm talking about deprescribing. Thank you, guys.
Thanks so much, Ken. That was great content. We're going to carry right on to Susie with kind of quality improvement application, and then we'll definitely have time for questions and discussion after that.
That sounds great. Thanks so much. Hey, everyone. It's great to be back with you this week. So today we're going to talk a little bit about improving communication and sort of how that relates to polypharmacy. So let's go ahead and go to the next slide, please. So again, just a really important point around reducing polypharmacy is really just making sure that our residents are on the right medications from the beginning. That's a mouthful. So today we're going to talk a little bit about communication. We are going to review SBAR, which I know is not new to most of us, but we're going to sort of review how to use it effectively as well. And I think there might be some key take-home messages there. And we're also going to touch on some tools as well as approaches to make sure that our communication is effective. So let's go ahead and go to the next slide, please. So in terms of communication challenges, communicating effectively in our world is really hard, particularly when we're busy, when we're understaffed, when we're orienting new staff onto our team, as well as maybe using some contracted staff. So sometimes that communication element is sort of the first thing to go. We're rushing from point A to point B. And so often we do experience some communication problems. They are really prevalent in nursing homes. Many medical decisions, as you know, are kind of made over the phone. And those generally stem from sort of brief conversations between sort of our nursing staff and our providers. So this can really sort of lead to some prescription errors, particularly in terms of stemming from really having inadequate information when we're sort of ordering those meds. So, having the appropriate medication or the appropriate information at the right time includes having information about relevant medical conditions, concurrent meds, potential drug interactions, as well as lab test results. Ken spoke a lot about how complex our medical regimens are. We often have a lot of providers covering our residents. Sometimes we don't have the health IT to really support these good decisions. Our residents are moving around a lot. So for all of these reasons, it's really great to have sort of a framework to guide our communications between our nursing staff and our providers. So let's go ahead and go to the next slide. So again, SBAR is nothing new. Really using it effectively and making sure that we're using it every time can really sometimes be a challenge. So I think everyone knows SBAR stands for Situation, Background, Assessment, Recommendation. And this is really just a framework for making sure that the right information is being communicated every time between nurse and provider. And so this really has the potential to reduce some prescribing errors. And so, like I said, I don't think this is new for anyone, but Situation really just provides you an opportunity to communicate sort of a concise statement of the problem. The background provides you with an opportunity to give any sort of relevant information. We want this to be brief, but we want to make sure that we're explaining the situation appropriately. The assessment is our own personal assessment analysis of any sort of considerations of and/or options. And then finally, the recommendation is our recommendation or what we want to recommend for the person prescribing. On the bottom of the screen, you'll see an SBAR tool, and this was put together by IHI, and it really features a template and some tools that you can use if you're looking to maybe educate your teams or your staff in terms of SBAR. So let's go ahead and go to the next slide. So here you'll see, this is just an SBAR template. There's a lot of ways. Again, this is just to try to help people to remember what they should include in their communications. So you can see here, this is a tool, and I'm not going to go into this in any great detail. Very simply, on the left-hand side is sort of a visual of those elements that folks should include when they're communicating with providers. And then on the right-hand side is a space where they can write that down ahead of time if time permits. But again, really having that sort of piece of information to remember exactly what to communicate each time is super helpful. Okay, let's go ahead and go to the next slide. This is just an example. Again, I just kind of included it for people to use if you're doing some in-services or training staff. You can see here, and again, this stems from the IHI's toolkit. There's a few great examples in there. Sometimes folks can remember things a little bit better if you share examples with them. And this gives you a really great sort of template. There are a few examples that are included in that toolkit. Sometimes we see sort of less experienced clinical staff. Sometimes they're a little bit anxious about making the recommendations. I've seen this a lot in sort of in all clinical settings, really across all levels of care. So when this is the case, we just want to be able to offer some extra support for them, provide some encouragement. Sometimes training can go a long way, so maybe do a little bit of role playing or helping them to get comfortable in that space. Again, like I said, a good place to start is maybe using a tool to help them to remember, maybe having a supportive colleague kind of walk them through that. Maybe they could shadow a supportive colleague. And again, role playing is really helpful in these situations. Some other tools, and I shared one earlier, but some other facilities have found that using notepads or having some paper with a tool printed on them are really helpful. Some other facilities I've seen use some pocket cards to help folks remember sort of what SBAR is. Some people have some stickers on their phones that might be a useful aid. So again, whatever works for your team or your organization, but it is really super helpful to have sort of that piece to remind you. Okay, so let's go ahead and go to the next slide. So in terms of improving communication, this is a good example of just an area that we need to continually monitor. So, looking kind of past any sort of paper compliance, we really want to make sure this process is working well. And that can really help to improve communication within your facility. So a great place to start in doing this is really kind of reviewing your existing process. Ask the folks that are closest to this, ask a sample of providers, how is communication working? Are you getting the information that you need? Are you satisfied with the communication process? You can also do a little bit more of an informal or formal review and look at the percent of SBARs completed each month. Again, you're looking for accuracy and completion. You can also ask your care team, what is working? What is not working? How can we make this better? Oftentimes they have some really great recommendations. You just need to take the time to sort of circle the wagons and talk about it. So once you've sort of gathered all of that information, you really want to just identify one area to improve. You can use a standardized form that we talked about. A lot of EHRs have some forms built into them. I'm curious if any of you all have seen that or if you're using that. And how that's working. But really, you just want to make sure that folks are using the tools and make sure that they continue to be used. Okay, let's go ahead and go to the next slide, please. So just in terms of key points, I think we covered effective communication is just so critically important in healthcare. I think we all know that. It's important for patient safety. It's important for reducing medical errors. In terms of SBAR, like I said, it's nothing new, but it is something that we need to sort of continually monitor and make sure that it's being used well, and just making sure that we're constantly helping our teams and helping our staff make sure that they're communicating effectively. It really can go a long way. Okay, so on the next slide, I have just a couple of references. Like I said, there's the toolkit from IHI. It has sort of everything you need to start in terms of SBAR, if you're doing some in-services or some additional education, and then a great article from AHRQ. So with that, thanks everybody for listening today. I think we had a question or two from Ken, but I will go ahead and turn it back over to the planning team. Thanks, everybody.